Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Block 9, Trauma, Episode 4, Motor Vehicle Collisions and the Older Adult. After viewing this episode, participants will review common injury patterns associated with older adults involved in motor vehicle collisions. Also, participants will review the management of older adults involved in motor vehicle collisions.
When you arrive on a motor vehicle accident, the first thing that you want to worry about is your scene safety. Is the scene something that you can approach, or do you have other issues that you have to deal with, down power lines, gasoline, vehicle fire, etc.? As soon as that is determined safe, you have to determine the number of patients that you're going to deal with and determine the severity of those. Once you have triaged how many people you have and how many resources you need, then you can start dealing with the ABCs of those patients. Are any of those patients critical? And this takes all of about 60 seconds to 2 minutes to determine that on most 1 to 2 car MVCs, to determine who's the sickest patient and who needs to go first. Once you have determined that and you determine what resources is dealing with the patient, C-spinal mobilization, oxygenation in the car, and then extrication via either a long board or a KED. If the patient is stable enough, a KED should be used to maintain their spinal mobilization. If they are unstable, they should be rapidly extricated to a long board, at which time they need to have a thorough trauma assessment outside of the vehicle, determine the extent of their injuries or possible injuries, and then determine if they are requiring of advanced life support skills or just basic life support skills, with assessment of vital signs, primary survey, secondary survey, and all appropriate treatments for their injuries.
So injury patterns that you see in geriatric patients in motor vehicle collisions, you actually see a higher propensity of people who don't wear seatbelts. So you see more head injuries, more cervical spine injuries, worse chest injuries, as the driver sits in the component in the car, well, any place in the car, the side to side, you tend to have bilateral rib fractures more commonly in a geriatric patient, worsened head injuries with relatively minor trauma because of the shrinkage of the brain and the bridging veins, and a higher propensity of subdural injuries. You tend to see more acetabular and hip fractures because of the osteoporosis in the geriatric patient population. As their knees hit that sort of the front panel of the car, you'll tend to see more acetabular fractures than you do in younger patients, because the acetabulum is a little weaker, where a younger patient would break their femur. The elderly patient is more likely to break their acetabulum. And I think it's very easy to get distracted with, oh my goodness, grandma has 3 different mangled lower extremities, her lower extremities are mangled, her upper extremity is mangled. But I think we're as guilty in this in the younger patient as we are in the older patient, staying with the fundamentals. How is their airway? Are they breathing? What is their, what are their vital signs? Do they appear to be perfusing? And then remembering truncal injuries tend to kill the chest and abdomen. So if they're not adequately breathing and their blood pressure is bad, their broken leg isn't going to matter, because they'll perish from their truncal injuries.
With all patients, especially geriatrics, if you have a trauma patient that is involved with an altered mental status, you must determine if this is due to a glucose issue, a drug issue, or a head injury. Is this due to low blood pressure, low pulse rate, hypoxia, etc.? So you go down through all of your standard altered mental status protocol and try to determine where the patient falls, and if you have no other reason for this, is this patient normally altered due to dementia, which is always a consideration when you're dealing with the elderly. Alzheimer's is becoming more and more prevalent in our country, and as such you have to take that as a consideration, but you should always exclude all medical problems and trauma prior to that.
When responding to a motor vehicle collision, it is important to perform a scene size-up. This includes scene safety, identifying the number of patients, identifying the number of resources needed, and the severity of injuries. Older adults may suffer more head, spine, chest, and acetabular injuries. Altered mental status can be caused by a variety of traumatic and medical mechanisms. A complete physical exam will help identify injuries that need treatment.
I can recall a difficult extrication. Patient had osteoporosis, and therefore the curvature of their spine due to their kyphosis required that we had to be very careful in how we collared and extricated her. She had some broken extremities and had suffered quite a deal of trauma to her chest from the steering wheel pre-airbags. As a result, we wanted to rapidly extricate her but maintain some type of spinal stabilization. So we actually had to pad the KED with pillows and try to immobilize her the best way we could so that we could keep her spine in its natural alignment due to her disease state, while at the same time rapidly extricating her. KED is appropriate to use when you have a patient that is fairly stable and doesn't require immediate action as far as their airway, their breathing, or their circulation. If they're stable enough that those three portions of your exam are stable, then a KED is a perfectly acceptable. The suspected spinal injury immobilization protocol, the elderly are specifically called out as if they are having injuries and such, that they are age excluded from that protocol, and as such don't fall, if they're over the age of 65, under that. They are to be immobilized as you normally would, due to the fact that they have these other issues dealing with their disease states and their more likeliness to fracture bones and such.
Older adults are at increased risk for spinal injury. They should always be immobilized for precaution in motor vehicle collisions. The Kendrick excavation device, KED, should be used in non-emergency situations. After the KED is applied, the patient should be transferred to a longboard. Always assess the patient before and after immobilization.
So managing trauma patients in the field, or geriatric trauma patients in the field, I think the biggest challenge for the elderly patient is how to appropriately immobilize them and how to deal with their pain control, and how to properly extract this patient that doesn't quite, isn't as malleable as a younger patient might be. Common things, most patients you would bring in backboarded and collared, but this is a patient where you're going to need to pad their pressure points. That backboard on that elderly patient for 25 minutes in the field is more likely to result in the beginning of a decubitus ulcer for the 80-year-old than it is for the 20-year-old. There's just nothing, there's not as much subcutaneous tissue, and their skin quality is not as good. Much higher propensity for that. Needing to differently immobilize, supporting a kyphotic back, changing the way you immobilize the cervical spine. You may not be able to use your standard cervical collar. You may need to use something a little bit differently for that. Not forgetting about pain control in the elderly patient. Rib fractures are painful. Supporting someone's breathing. You're going to have a lower threshold for intubating an elderly patient. But the caveat to that being, their head positioning is going to be worse. Their mouth opening tends to be smaller. Some don't forget to remove their dentures, but then at least the teeth are out of your way. So those sorts of things are challenging when you do manage their airways, but a lower threshold for intubating. Everybody absolutely needs oxygen because they just don't have the same pulmonary reserve. Pain control, and when in doubt, splinting extremities. When you go with fluid resuscitation in the field as well, in the geriatric patient, you're going to be a little bit careful with just opening your IV bags wide open. That patient may not be able to process those extra 2 and 3 and 4 liters of fluid they get in the field, and not end up in florid pulmonary edema from that, not end up in congestive heart failure from that, not end up with other issues from that. So let me a little bit cautious with that. Keeping elderly patients warm is exquisitely important. Whether they're burned, not burned, whether they have anything broken, not broken. There's something in triad we like to call the triad of death. It's hypothermia, acidosis, and coagulopathy, and it all starts with being cold. You're cold, you bleed, you get more acidotic, your clotting systems don't work as well. Your normal endogenous pressors, or things that regulate your blood pressure endogenously, don't work as well. Your blood pressure gets lower, you get more fluid, you get colder, and it all continues. In an elderly patient, they already are at risk for hypothermia just with the changes in their skin as they age. So tuck grandma in and keep her warm.
The older adult should receive extra padding and special considerations for spinal immobilization. Pain control, oxygenation, and splinting are essential in the older adult trauma patient. Be cautious when giving IV fluids. Some older adults will not be able to tolerate large amounts of fluid, resulting in complications. Older adults are more prone to hypothermia, which can have significant negative outcomes if not prevented. After viewing this episode, participants will review common injury patterns associated with older adults involved in motor vehicle collisions. Also, participants will review the management of older adults involved in motor vehicle collisions.